Good morning, good morning, good morning, and happy New Year to every one of you who I have not seen since the beginning of the year. It is so exciting to be back for our first meeting of the 2024 calendar. I would like to wish each and every one of you a successful, happy, and healthy new year ahead, filled with enriched educational experience. It is indeed with a great pleasure that I welcome you today. We have some very, very exciting things planned for this year of 2024 to help you to level up in your education and at the same time help
Good
you
morning.
to fulfill.
Sorry, a lot of feedback.
Okay, I'm hearing that we're getting a lot of feedback. Let's see if we can sort it out. Is that any better? Just bear with us for a second, please. Activities that we hope to bring forward to you this year. So you want to ensure that you are here and not to miss any of the series that we have for you. Diabetes is a medical condition that is significant in the Bahamas because of its high prevalence and associated morbidity and mortality. Therefore, it is of extreme importance that we are aware of the current guidelines for its management to win in the fight against diabetes. Therefore, today we will arm you with such information to win this fight. We are pleased to have with us today Dr. Ariane Davis Simmons. Now, for those of you who may not be familiar with her, I will help you out. Dr. Davis Simmons was born in Freeport, Grand Bahama. She is a part of a medical family as her older sisters practice pediatric dentistry and pulmonary critical care, respectively. After completion of her high school years in Freeport, Dr. Davis Simmons attended the University of Maryland and graduated in 2004 with a Bachelor's of Science in Biology. She pursued medical training at the University of the West Indies in Trinidad and completed her clinical training at the Nassau campus, graduating in 2010. She worked briefly at the Princess Margaret Hospital as a senior health officer and later pursued training in internal medicine at the University of Maryland in Baltimore. After graduating and completing a chief resident position in 2016, she began subspecialty training in endocrinology, diabetes, and metabolism at MedStar Union Memorial Hospital, graduating in June 2019. Her interest in diabetes and endocrinology began early in her medical training, spurred by the diagnosis of diabetes in her father and type 1 diabetes in her 9-year-old niece. She initially watched them struggle in different ways in their diagnosis and management, and knew that if she understood this field, that she would be able to make a difference. Her expertise include, but is not limited to, diabetes management, diabetes technology, insulin pumps and continuous glucose monitors, thyroid disorders, thyroid ultrasound and biopsies, medical obesity management, pituitary, parathyroid, and adrenal disorders. Growing up in the Bahamas and having her formative medical training here, she decided that it would have been good to come back and give back to her community. So just before we welcome Dr. Davis Simmons, we would like to open the meeting in prayer. Father God in heaven, we come before you this morning, thanking you for this beautiful day. We thank you for all of the many blessings that you have given to us. We thank you, oh God, for giving us the strength to do what we do. And we do not take it lightly, oh God, because we know that this is a mandate. As we begin our educational series, we pray that you would be with us, open our minds to receive the information that will be given to us today, that we will be able to go out there and do your work in helping the patients that you entrust into our hands. Be with us, O God. Bless us, guide us, keep us, and protect us. This I pray in Jesus' name. Amen. Welcome, Dr. Davis Simmons.
Hi, thank you for that introduction. Let's share. Are you guys seeing my screen?
Yes, we are.
Perfect. Give me 1 second. Okay. So yeah, thanks for that warm introduction. So we're going to talk about updates in the treatment and management of type 2 diabetes. I have no financial disclosures or conflicts of interest. Here are our objectives. Hopefully we get through most of them. So we're going to talk about a little bit about the prevalence of diabetes in the Bahamas, pathophysiology, updates in the standard of care, pharmacological agents, and the evolution of diabetes management using these agents. And we're going to focus on some of the newer agents, the SGLT2 inhibitors, GLP-1 receptor agonists, and the dual therapy GLP and GIP agonists. We're going to talk about some mechanisms of action, landmark trials, glycemic and extraglycemic effects, guideline updates, and side effects and combining therapy. If we have some time, we'll go through a couple of cases so you can see how I would tackle it. And at the end of the talk, you should be able to develop a treatment algorithm for type 2 diabetes treatment that's consistent with the standards of care. You should know how to prevent clinical or therapeutic inertia and to prevent futile kind of polypharmacy and how to manage diabetes-related complications. So key facts. 12% of Bahamians have type 2 diabetes, 7 to 2% have prediabetes, so 20% have dysglycemia. Among those with diabetes, 55.3% admit to medication non-adherence, women more so than men. Diabetes is the seventh leading cause of death worldwide, according to WHO. It is one of the major causes of morbidity and mortality, and it leads to blindness, kidney failure, coronary vascular disease, strokes, and amputations. Increasing with this diabetes epidemic in the Bahamas, we also have increasing obesity. 27.9% of Bahamians are overweight. 43.7% are obese. And out of that percentage, more than half of Bahamian women are obese. So, in terms of the pathophysiology of type 2 diabetes, our understanding has evolved over the years. So, in the 80s, we had the concept that type 2 diabetes occurred for three main reasons. You had increased hepatic glucose production, you had declining insulin secretion, and you had increased insulin resistance, all of which led to hyperglycemia. So the medications we had at that time kind of focused on targeting those defects. So that was like metformin, sulfonylureas, the TZDs, and then you had acarbose, which reduced carbohydrate absorption. However, our understanding of diabetes has evolved. So type 2 diabetes is a lot more complex than we thought. So there are multiple defects that happen, all of which that lead to hyperglycemia. So newer concepts show that there is a decrease in the incretin effect. So the incretin effect are peptides or hormones that increase when we eat, and they synergistically increase insulin release, and they also have effects on the brain for appetite satiety. We also know that the kidneys have defects in individuals with diabetes, where even though the sugars are high, the kidneys are reabsorbing more sugar. So it has a maladaptive mechanism. So the newer medications or the evolution of the medications have evolved to target these defects. So as the medications expanded and diabetes management became more complicated, ADA decided to put out the standards of care. So they started doing that in 2018. They release it every December. And it is a living document. So any new studies that show benefit, new medications, new technology, it is then added into the standards of care. It is a very dense document. It's about 300 plus pages, but if you have the time, I would recommend that you peruse it. So we're going to talk about some of the new updates to the guidelines in these areas. So comprehensive medical evaluation, positive health behaviors, diabetes technology, obesity management in type 2 patients, CVD and CKD risk management, and then we'll talk about the pharmacological approaches to glycemic management. So one of the new updates was to the comprehensive section where they focused a lot on non-alcoholic fatty liver disease or NASH. So this nomenclature has evolved and changed. So last year it was named NAFLD, went to MAFLD. So it's metabolic associated fatty liver disease. And the change in the nomenclature is to reflect what was the etiology of why these patients develop fatty liver disease. So the ADA standards of care recommend that all type 2 diabetes with overweight or obesity status are screened for liver fibrosis, even if they have normal liver enzymes. So they recommend that you do a FIB-4 score in these individuals. If individuals with type 2 diabetes, prediabetes, or diabetes have elevated ASTs, but the FIB-4 score is normal, they recommend that you evaluate them from other causes of liver disease. They have a nice flow chart algorithm of how you should assess these individuals. So all type 2 obese, overweight individuals will get a FIB-4 score, and then they are categorized either low risk, intermediate, or high risk based on that FIB-4 score. So low risk individuals will have repeat assessment of their score in 2 to 3 years. Intermediate risk individuals who scoring 1.4 to 3.25 on the FIB-4 score, so stage 2-3 fibrosis, should then go on to have more provocative testing with elastography or blood tests to screen for fibrosis markers. And then once that's done, they will then be categorized as low or high risk. If they're categorized as high risk, they should be then referred to the gastroenterologist or the hepatologist. Under the NAFLD, criteria, they're recommending that you recommend lifestyle changes that promote weight loss, to have a structured nutritional plan. The patient should also have a physical activity plan, all the goal to improve cardiometabolic benefits. You should be using medications such as GLP-1 receptor agonists or combination therapies, GIP, GLP-1 receptor agonists that will aid in weight loss. These medications also do improve NASH outside from weight loss. It improves fibrosis score and can lead to resolution of NASH. Other medications that have shown benefit, pioglitazone should be an option, or GLP-1 receptor agonist. A new recommendation is that individuals who have type 2 diabetes, obesity, along with NASH should be recommended to metabolic surgery if appropriate, because we know the metabolic surgery leads to about 60% of excess body weight loss, about 25 to 30% of overall weight loss. So it does lead to resolution of NASH, and can also lead to the remission of diabetes. Under positive healthy behaviors section, they recommend strongly, as they always do, that patients are seen by diabetes educators and support teams so that they can learn self-management. 90% of diabetes management is self-care. What we do in prescribing is 10% of it. It's what the patients do when they get home, how to eat, when to eat, how to take the meds, how to monitor, how to adjust the medications based on the blood sugars. So diabetes self-management should happen at four critical points in a diabetic's life: at diagnosis. It should happen annually. It should happen when you notice that the A1C is not at target. When there's complicating factors, so health conditions, maybe there's new onset CKD, physical limitations, anything that will impact self-management, that's a time to get reassessed by the diabetes educator. And then when transitions in life occur. So if children with type 1 who are now transitioning to adult clinic, that's a time to get back in with the diabetes educator. Under technology, they are recommending that we use sensors more, so more CGMs, because this helps with self-monitoring. This helps with behavioral modification. It helps them to know how the foods affect them, so hopefully they'll avoid those foods. So they're recommending that for individuals who are on multi-dose injection, so basal bolus therapy, Lantus Humalog, or who are on insulin pumps. And they also are recommending even for individuals who are just on basal insulin, so maybe just Lantus, Toujeo, and orals, they are recommending that they will still benefit from a CGM. So in the obesity section, I would say this is one of the sections that kind of has been evolving the most in the last coming years, is that they recommend that obesity management is one of the primary goal endpoints, because we know obesity is very much tied to diabetes. So this is a diabesity. So they recommend that you target that treatment. A minimum of a 3 to 7% baseline in weight improves glycemia. If someone has prediabetes, just losing that amount of weight leads to resolution of the prediabetes. A sustained weight loss of 10% or more confers greater benefit. It can have disease-modifying effects, like I said, resolution of NASH, 10-15% loss. If you have OSA, it resolves with 15% weight loss. And they recommend that you individualize initial treatment approaches. So it should always be lifestyle, nutritional management, pharmacotherapy. But again, they are recommending metabolic surgery for individuals who meet criteria. We should be pushing medications that prevent weight, that actually treat the weight loss, treat obesity. So GLP-1s, dual agonist therapy like Mounjaro, and they want you to prevent therapeutic inertia. So if you are seeing the patient and you realize there's no weight loss in spite of lifestyle, exercise, and diet recommendations, then you should then either change the medication that's going to assist in weight loss or then refer these patients for metabolic surgery. So many studies show that reducing the weight leads to improvement into metabolic factors. And at the higher weight losses, there's more benefit. So greater loss, greater benefit. And like I said, resolution of diabetes can occur with 20% excess weight loss. And then 15%, you can have improvement of NASH and OSA. So this is a new update in terms of metabolic surgery. They used to recommend it for patients who were 30 BMI of 35 and over and type 2 diabetes. So now they're saying if your BMI is even over 30 and you have type 2 diabetes, you can consider metabolic surgery because again, this can lead to remission. So there's lots of studies that show benefits of bariatric surgery. This is just one study that I pulled. This is looking at teens who had type 2 diabetes, who went on to have had metabolic surgery, so bariatric surgery, Row and Y, and then they looked at adults. So all of these individuals had type 2 diabetes and obesity. They underwent bariatric surgery, and they all had similar weight loss, and they maintained the weight at the 5-year point. However, when they looked at the subgroups with the diabetes, the adolescents had more remission of the diabetes where their A1C was less than 6 in comparison to the adults. Why does this happen? The weight loss was the same. It is because we know diabetes is a progressive disease. So the longer you have it, you're going to have beta cell decline, insulin decline, beta cell failure. So if these patients meet surgical criteria, it's best to do it early so that they can have remission instead of doing it later where diabetes may persist. It may get better, but it's not going to resolve. So in terms of blood pressure and cardiovascular management, treat if blood pressure is greater than or equal to 130/80. This is a change in the guidelines in terms of dual therapy. They used to recommend it if blood pressure was over systolic of 160. Now they're recommending if it is over 150, so 2-drug therapy. And as usual, it always should be first-line ACE inhibitor, angiotensin receptor blocker. For statin therapy, all diabetic patients age 40 to 75, even if they don't have cardiovascular risk, should be on a statin. So moderate intense statin, because diabetes itself is an ASCVD risk factor. And the goal LDL is less than 100. For individuals 20 to 39 who have ASCVD risk, you can consider starting a statin. And then individuals who have multiple ASCVD risk factors, you should be on high intensity statin, and the goal LDL is less than 70. For those who have multiple risk factors and unable to achieve the goal LDL of less than 70, you can consider add-on therapy with maximally tolerated statins, add on ezetimibe or a PCSK9 inhibitor. And all patients with diabetes and ASCVD should be high intensity statin. They should have lifestyle. And if they've had an event already and you're doing it for secondary prevention, LDL goal is less than 55. For individuals who can't tolerate high intensity statin, then use the max dose of the statin. If they're unable to get to that target LDL, again, we add on therapy. That can be the PCSK9 inhibitor, the monoclonal antibody, or bempedoic acid, which all will help to lower LDL and help to prevent a future event. In chronic kidney disease, they made some updates to the screening. This is an old one. This should be that you're doing a microalbumin at least once a year if they have normal GFR. In patients who have CKD, you should monitor their albumin anywhere 1 to 4 times a year, and it should vary depending on the stage of the kidney disease. As usual, always optimize glycemic control, optimize blood control primarily. First line will be ACE or ARBs. And for individuals who have type 2 diabetes and CKD, if their GFR is over 2025, consider adding of an SGLT2 inhibitor, which can slow down albuminuria and prevent the progression to end-stage disease. And then as an addition, if you need more glycemic control, you can add on a GLP-1 agonist or consider a non-steroidal mineralocorticoid receptor antagonist such as finerenone, which will also help to prevent the progression. So this is just a nice flow chart that shows the steps of management. So you're going to screen for albuminuria, and it tells you also when to treat and then when to refer. So you really want to refer to nephrology if they are having significant albuminuria, if GFR has now declined less than 45 with albumin. And then you want to optimize those medications that I talked about. So it would be blood pressure control, ACE and ARBs, glycemic control, SGLT2 inhibitors, adding on a GLP-1 agonist, and then consideration of finerenone. So when we look at the pharmacological therapy, this part of the guidelines have changed a lot. So, back in the early 2000s and 90s, when we looked at all of the past studies, it was all about sugar control. It was all about glycemia. So we had studies that show good control obviously prevents downstream morbidity and mortality. But the standard of care at that time was A1C of 7 to about 7.9. However, the Accord trial was one that looked at intense therapy. So this was targeting an A1C of 6.5 or less in comparison to standard care. And in that study, it actually showed that it was less favorable. So there was more events, there was more mortality, so it was higher risk. And it was likely because of the medication that they used at that time. So the lowering agents at that time would have been, the potent ones would be insulin, sulfonylurea as add-on to metformin, and then lactose. So the evolution of type 2 diabetes management, when we look at it from the beginning, in the early 80s, they're concerned about sugar, but they were also thinking about glucose independent factors. From the 1990 to about 2008, we became all glucose centric. It was all about the A1C. And then in 2008 to 2015, based on the past and Accord trials, we wanted glycemic control, but we also wanted to prevent hypoglycemia. So in 2008, it's a busy slide, but in 2008, the FDA came out and they mandated that all diabetes medications prior to approval have a cardiovascular safety trial. We call it outcome trials, but they're safety trials to make sure that they were safe. Because as we know, there's a lot of cardiovascular disease in individuals that have type 2 diabetes. So we want to know that the medications are, yes, lowering sugar, but also having some benefit and not having undue harm. So when we look at the risk factors of cardiovascular risk factors in diabetes, coronary heart disease, there's a prevalence of 14 to 21%. Heart failure occurs in 19 to 26% of individuals with diabetes. This is the second most common initial manifestation. You have peripheral artery disease. This is the most common initial manifestation with a prevalence of 16 to 29%. And then you have stroke, which can occur in 8 to 12% of patients with diabetes. So it makes sense that if you're approving medications, that they will also improve those factors. So this is a summary of the cardiovascular safety trials. And let's start with one of the first medications that can help to prevent these cardiovascular risk. So we have the SGLT2 inhibitors. They work at inhibiting SGLT2 in the proximal tubules. This leads to loss of sodium and glucose into the urine. So you have diuresis, glucose excretion, and natriuresis. So this leads to improvement in myocardial sodium. It leads to decrease in intraglomerular pressure. It decreases left ventricular wall stress. It decreases inflammation. It decreases blood pressure. It has effects on body weight. It leads to improvement in glycemia, so improvement in A1C, cardiovascular risk. And its biggest effect is on kidney and preventing chronic kidney disease progression. So this is a summary of the cardiovascular safety trials for SGLT2 inhibitors. So in overall MACE events, which look at reduction of cardiovascular death, heart failure, or any cardiac event, there was reduction across the board, but most of the reduction was due to, when they pooled it, was due to the reduction of heart failure, exacerbation, and hospitalizations for heart failure. And as you see, it is a class effect. All of them showed some benefit ranging from 30% to almost 35% in a risk reduction. When we look at heart failure studies, even in patients who don't have diabetes, these medications show benefit and reduce the risk of heart failure, exacerbations, cardiovascular death, and overall MACE. So in the renal trials, I don't have MPA-CKD on here, but they all showed similarities. So Credence, DAPA-CKD, and MPA-CKD, which were studies that were done primarily for renal outcomes, and they were done in individuals who had a lower GFR, depending on the study, ranging from a GFR of 25 to about 40, and then with significant macroalbuminuria. And they all showed benefit, which the primary outcome would be assessing was progression to CKD, worsening GFR, or needing hemodialysis. And they all showed significant benefit. If you look at the dapagliflozin, it led to a reduction of almost 44% of in individuals of progression, 44% reduction. So it is tremendous. When we look at some of the, again, one of the newer, well, not so new agents, GLP-1 receptor agonists. This is a list of available agonists. And then lastly is the combination therapy, which is Mounjaro. So that is the newer kid on the block. That's the GLP-1 receptor agonist and GIP agonist, so the dual therapy. So this graph or this chart shows where the receptors are. So GLP-1 agonists, GLP-1 agonists, GIP agonists have effects all over the body because these receptors are all over the body. So the red is GIP receptors and the blue is the GLP-1 receptors. So there's receptors on the brain, there's receptors on the endothelial cells of the vasculature system. They're on the heart. They're on the pancreas, the liver, the stomach, the bones, the fat cells. So this is why they have kind of a wonderful effect across the board. So we know these medications lead to appetite suppression because they work at the level of the brain. So that's what leads to weight loss. It has effects on the heart, cardioprotection. It can help with contractility. It helps to prevent cardiovascular risk. It reduces hepatic steatosis at the liver. It increases insulin production in a smart way. When you eat, it increases insulin production. It reduces glucagon. It's renoprotective, reduces blood pressure and has and reduces inflammation at the gut level. When we zoom in to the cardiorenal benefits, so the heart has both GLP-1 and GIP receptors. When you have an agent that binds tightly to those receptors, it can lead to cardioprotection, increased myocardial contractility, increasing your heart rate, and it helps to increase glucose uptake at the blood vessel level. It leads to vasodilation, systemic inflammation, reduction of the foam cells, reduction in the macrophages. And at the level of the kidney, it has nephroprotection. It creates sodium excretion, so diuresis, reduces blood pressure, and helps to slow microalbuminuria. When we look at the outcome trials, and we looked at the 3-point MACE, so reduction of cardiovascular death, fatal or non-fatal MI and stroke, the more potent GLP-1s did show some benefit. So that would be the liraglutide and the semaglutide. So they had a reduction of the liraglutide 13% at 3-point MACE and the semaglutide 26% reduction. And they also had benefits at the level of the kidney. So when we look at cardiovascular outcomes and we look at the GLP studies, the SGLT2 studies, you can see that they show benefit. They reduce cardiovascular risk. With the SGLT2s, it's mostly through reduction of heart failure, where in the GLP-1s is reduction of either a primary event or a secondary event. And when you compare them to other incretins, like DPP-4, which are really weak performers, they don't really have any cardiovascular benefit. When we look at NAFLD and the treatment of MAFLD, GLP-1s they improve the condition by reducing insulin resistance, reducing inflammation, reducing oxidative stress, reducing triglycerides, and they have great effects on the disease. So this is looking at semaglutide in individuals who had NASH, who had F2 or F3 fibrosis. They followed these patients for 72 weeks. They did not give them weekly semaglutide. That's how it's traditionally prescribed, but they gave them small doses of daily semaglutide, which is Ozempic. And as you see, the percentage of patients that had resolution of NASH was 59% in comparison to 17%. So it was a 30% improvement in comparison to placebo. There was also improvement in liver fibrosis stage without worsening of the NASH in the semaglutide groups also. GLP-1 receptor agonists, when we compare them to the other non-insulin therapies, they perform very robust in terms of their A1C lowering capability. So the more potent agents lead to a 1.8% reduction in A1C when they're used as monotherapy. And when you look at the semaglutide, which is in the red, they were looking at actually with a lower dose of semaglutide. So highest dose semaglutide would be 2 milligrams. So this was at 1 milligram, and it was a 1.8% reduction. And with the 2 milligram dose, you have an additional 0.5% reduction in the A1C. And we all know, because it's all over social media in terms of its weight effects, because everyone's using it off label, is that it has a great effect on the weight. The more potent agents that bind more tightly to the receptor have greater effects. So that would be semaglutide, but also liraglutide has some weight benefits. So semaglutide, the higher the dose, the more weight benefit. And the weight loss in these more potent agents can be up to, in terms of mean change in weight kilos, around 7 kilos. So about 14, 15 pounds in weight. And we'll talk about some of the newer agents also. So Mounjaro is the newest kid on the block. That's the GIP, GLP-1 dual agonist. There are other dual and triple therapies in the pipeline being studied. How does this work? It has GLP and GIP binding, but it has a more potent effect at the GIP receptors, which are in the intestine and all over. And it leads to increased first and second phase insulin secretion. It leads to reduction in glucagon levels. It helps to improve insulin sensitivity, reduce it, causes satiety, so you eat less, and it slows gastric emptying. It is more potent than the GLP-1 receptor agonist. So it's more potent than Ozempic at these targets. It works through CAMP to help reduce glycogen and glucose and lipids. And when we look at the tirzepatide trials, so this is the Mounjaro trials, so this is looking at SURPASS 1 through 5. And when we look at the A1C reduction, whereas the GLPs would be 1.8 to 2% reduction, the higher dose Mounjaro is achieving about a 2.5% reduction in A1C. So those are levels we see with insulin therapy, not really with non-insulin therapy. And then body weight reduction, you have a benefit where this one is giving you more weight loss. So you're losing 10 to 12 kilograms. So on average, maybe 24 to 25 pounds. And if coupled with lifestyle modification, the weight loss could be much more tremendous. So the other thing with the SURPASS, which is changing the paradigm, is that individuals in the studies were achieving A1Cs less than 6.5. So these patients were being pushed out of the diabetes range into pre-diabetic range, but they were also having weight loss and no hypoglycemia. So this is very different from past studies, which showed actually more harm with tighter glycemic control due to the use of hypoglycemic agents. So, so Mounjaro set or tirzepatide set a new benchmark in diabetes because this chart is showing the percentage of patients that achieved A1C less than 5.7%. So this means they reached euglycemia. They were in the normal range, and then they had weight loss and they had no hypoglycemia. So it proved that it is possible with newer agents to reach these targets. So these studies have led to a paradigm shift in diabetes. So we've moved from the glucocentric, then we were in the complication centric, which was based on ASCVD risk reduction, CKD risk reduction. But now we are moving past that. So yes, we care about reducing cardio and renal risk. We care about weight loss, and we also care about glucose. So targeting adiposity and obesity is an evolution. So we are moving from hypoglycemic agents that didn't modify the pathophysiology to truly anti-diabetic agents that are reversing the defects and modifying the disease, leading to even remission. So it's an exciting time. So it's definitely a paradigm shift where we're treating diabetes as a whole. So if we treat the obesity, then all of these metabolic issues kind of go away. OSA, NASH, OA, hyperlipidemia, hypertension, coronary artery disease, which the latter three lead to macrovascular diseases. You're targeting type 2 diabetes and even putting in remission. So you're preventing microvascular complications. So it begs to say that the way we used to do it before wasn't the best. A glucocentric approach, yes, is important, but have upstream intervention so we prevent those long-term complications. So when we look at this is the ADA guidelines, it is a busy graph. But these studies have changed and it's a paradigm shift. So before we used to say metformin first line for everybody. And that's kind of changed with the ADA guidelines. So what they're looking at is, do you have cardiovascular risk? Do you have obesity? And then we're going to start with those medications that are going to have the best benefit. So if you have a history of high ASCVD risk, you're going to start with a GLP-1 receptor agonist. That's going to be Victoza, Ozempic, and then you can add on an SGLT2 inhibitor. If you have heart failure or you have CKD, you're going to start with the SGLT preferred, and then you can add on a GLP-1 after if more glycemic lowering is needed. If there is obesity, then you're going to start with a GLP-1. So if there's no obesity and no other metabolic issues, and it's just, you're a lean type 2, then you could start with metformin. But all the other indications, you're going to start with one of the newer medications. So also with the guidelines, they're recommending that the first injectable you use is a GLP-1 receptor agonist. And if patients are then still not at goal, you can consider adding in insulin at that time. So if they're on metformin, metformin, SGLT2 inhibitor, the GLP should be the first injectable. And then if needed for glucose lowering, you can add in insulin therapy. And as they always remind, it's important to prevent therapeutic inertia. So you should be following up these people regularly. So add-on therapy can be started if needed. They're recommending at least every 3 to 6 months. When we look at the ACE guidelines, they give a little bit more guidelines. So the ADA tells you kind of what medications to start. But ACE is a little more aggressive where they're saying, hey, if the A1C is more than 7.5%, consider dual therapy. Don't wait. So you have that therapeutic inertia, bring them back 3 months and then add on. So when they look at their disease kind of breakdown, same, if you have ASCVD, you're going to start a GLP-1, heart failure, start a SGLT2. And if you have CKD and SGLT2, but if the A1C is over a certain percentage, think about adding dual therapy. So maybe an SGLT2 and a GLP-1 receptor agonist. And then you see where metformin is now getting pushed down to second line therapy. Another consideration that they have is that if A1C is very high, so if it's over 300, patients are symptomatic, the A1C is over 10, yes, these patients need insulin therapy, but maybe do basal insulin, then add a GLP-1, which will help with mealtime blood sugars, but also will help to prevent weight gain from the insulin. So if you do not have those risk factors, or if they're not the primary issue, then you can start with metformin and then you add on additional therapy thereafter. So this is just a summary of administering how these medications are administered, how you do the dose increase. So GLP-1 and GIP, so looking at GLP-1 and GI, the combination therapy. So Trulicity, which is a once weekly injectable, it comes in varying doses. The dose is increased every 4 weeks. It is a pen where you don't see the needle. You have Ozempic, which everyone knows, semaglutide. You get 1 pen a month. The doses are increased slowly every month, every 4 weeks. The lowest pen comes in a 0.25 pen or a combination 0.25, 0.5 pen. So when you're starting the dose, you'll do 0.25 weekly for 4 weeks, and then you go up to 0.5 for 4 weeks, and then you go up to 1 milligram for 4 weeks. And unfortunately, that's the highest dose we have in our market. So patients will stay on the 1 milligram if tolerated. When we look at Victoza, this is a GLP-1 agonist that is a daily. It comes in 0.6, 1.2, or 1.8. You start at 0.6 daily for a week, then you increase to 1.2 daily for a week, and then you go up to 1.8. So it's slowly titrated. And the reason we do that with GLP and with the dual therapy is because you want to decrease or mitigate the side effects, mostly the GI side effects. Those of you who've been in practice for a while will remember BCICE. So this is one of the first GLP-1 agonists. It's still on the market. It's just not used as robust as it once was. And then you have oral semaglutide, which comes in 3 milligrams, 7 milligrams, and 14. Similarly to the injection, that's dosed daily, and you're going to titrate the dose up each month. So you'll go from 3 milligrams daily for a month. It should be taken on an empty stomach before you eat, about 30 minutes to an hour before the meal. And then you increase it, if tolerated, the next month to the higher dosing. Manjaro comes in 2.5 to 15 milligrams, similarly to all the GLP-1s. It's a weekly, this one, and it is increased monthly. So you're going to titrate every 4 weeks to the higher dose, if tolerated. Potential side effects of GLP-1s, GI, because it works, the GI, it slows down gastric empty and the way that food is transited. So your body initially perceives that as nausea. Some people get constipation, some people get diarrhea, in particular if they overeat or they have a very high sugar meal. The peak effects of the nausea is around 48 to 72 hours. And that usually occurs after the weekly formulation. If you're on the daily, you may notice it that day, that evening, the next day. The GI side effects, for most, resolve at 2 to 4 weeks, but for some people, it may persist up to 12 weeks. Each dose increase may result in a new nausea. So when you go up in the dose, you may feel it and then it kind of dissipates. But dietary advice is important to minimize the effects. So because it slows down the transit, some people get more reflux. So you want to avoid them, tell patients not to eat foods that can also cause reflux. So spicy foods, greasy foods, large portions, things like that. So you want to give dietary guidance. And how you manage the GI symptoms depends on the severity of the symptoms. So mild symptoms, you can use over-the-counter stuff. You could tell them chew ginger tabs, things like that. For more severe symptoms where they're having a lot of nausea, reflux, you can use an antiemetic. You can prescribe a antacid or a PPI. And then more of the severe symptoms is gastroparesis or ileus, which have been reported with the more potent agents. How do we prescribe? So in SGLT2 inhibitors, I think most of us are familiar with this. Jardiance comes in 2 doses, 10 and 25. It also comes in combinations. Farxiga comes in 5 and 10, and it comes with combinations with metformin and DPP-4s. Invokana, ertagliflozin, which I don't think we have in the market here, which is Stelgatro, again, comes in combination. And it's important to know that the low dose and the high dose have similar side effects. The only difference is between the low dose and the high dose. The high dose has more rates of dehydration. or potential dehydration. When it comes to the GLP-1 agonists, who do we not want to use this in? That would be in individuals who have a history of pancreatitis. Now, if we know what's causing the pancreatitis, if it was gallstone pancreatitis and they already had a cholecystectomy, then yes, you can do a trial in these individuals. If they've had a personal or family history of medullary thyroid cancer or MEN2A or 2B, now, this has not been seen in individuals. It increases the risk of that, but it was seen in the animal rodent studies. So based on the animal studies, the recommendation is not to use these agents in individuals with a significant personal or family history. Use with caution in patients with gastroparesis, because these medications slow down the GI transit. So if you have gastroparesis, you're going to have a lot of GI effects. And for the older agents, Bydureon, lixisenatide, adalimumab, you cannot use at lower GFRs. So some of the contraindications for Mounjaro is the same as the GLP-1 receptor agonist. However, Mounjaro can reduce the efficacy of oral hormone contraceptives. So this is on the label, and the other GLP-1 agonists don't have this warning. So who do we not want to use SGLT2 inhibitors, or when do we take caution? It should not be used in individuals who have type 1 diabetes, who have, Invokana GFR less than 60. The newer agents can be used at lower GFRs, and there've been studies in that. So GFR up to 25 for Farxiga, so dapagliflozin, and for Jardiance or empagliflozin less than 30. If people have had DKA, you don't want to use this agent because it can precipitate euglycemic DKA. If they are planning for surgery, you should hold these meds 3 to 4 days prior, because it's causing dehydration. They're not eating. So this could precipitate a euglycemic event. So you want to hold it for a few days before the surgeon, maybe even after the surgery. Invokana is the only one that has the warning about peripheral vascular disease. The other agents in that class have not shown that it increases the risk of peripheral vascular disease. However, there is a class effect, we think, for reduction, for increase in fracture risk. So if individuals have severe osteoporosis, you may consider not to use this medication. And the caution in other scenarios. So if someone is having frequent yeast infections, urinary tract infections, you don't want to use this medication. If they're prone to dehydration, this medication causes diuresis, so you don't want to use this medication. So I tend not to use these in my little people, or little older adults, is because they're more prone to dehydration anyway. So we don't want to add on a medication that's going to cause that to happen more. You want to avoid in patients who have risk factors or predisposing to DKA. So ketosis prone type 2 diabetes, people who are on a ketogenic diet, you may not want to start these medications. And if they're on any other, if your patients are on any other medications that cause diuresis or act on the level of kidney, you want to have some caution. So for example, if they have heart failure and you're considering adding this on, and they're on Lasix twice a day, you want to reduce one of the medications. So maybe reducing the Lasix to once a day and then adding on this medication, because it also causes diuresis, so that you don't precipitate dehydration. A common thread through the guidelines is preventing therapeutic inertia. So what is that? So many people we know have type 2 diabetes and they never really achieve glycemic targets. We know diabetes, the longer you have it, it progresses. You have beta cell dysfunction over time. And clinical inertia is failure of healthcare providers to initiate or to intensify therapy when indicated. And this happens for multiple reasons. It could be physician dependent, where the physician may not be comfortable adding on an injectable therapy, so then they kind of do nothing and leave the patient with an A1C of 8 or 9. It may be patient dependent, where the patient does not want to progress therapy. It may be healthcare system related, where other medications may not be available in the health system. So these factors cause patients to be suboptimally controlled for many years. And we know if that happens, you get diabetes complications, morbidity, increased morbidity and mortality. So it is important to have intensive blood glucose therapy early because we know that has legacy effect down the road. So it prevents comorbidities, mortality, morbidity down the road by having intense therapy kind of upfront. So how do we combat it? Clinical inertia, it should be patient-centered. You should consider cost, route of administration. You do take in patient preference and weight effects. It's important to educate patients. If they don't do anything, this is the things that can happen. So you got to educate them about the increased morbidity and mortality. If patients have an A1C of 8%, you're going to think about combination therapy. So we'll talk about the low A1C lowering of some of the other agents. But an A1C of 8 or more, 8 or 9, metformin alone won't cut it. It will not get you to goal. So you have to have some understanding of how much A1C lowering these medications create, and then also getting diabetes educators involved to help with self-management. So in terms of the medications, the non-insulin therapies that have the highest or most robust A1C lowering are going to be your incretin therapies, your GLP-1 receptor agonists, and your dual therapy, with Mounjaro reducing up to 2.3%. Other agents, sulfonylureas, 1.17% reduction. I don't know if you looked at the guidelines, the graph from ADA. Sulfonylureas are pretty much not on there anymore. It's unless it is a cost issue. Metformin is about 1% reduction. SGLT2 inhibitors, 1%, but really around 0.7 or so percent reduction. The pioglitazones, Actos have a reduction of almost 1%. DPP4 is really a poor performer, really somewhere between 0.5 and 0.7% reduction. And insulin, depending on the dosing, is going to give you a drop of 1.5% or more. And if you have the patients titrating to a fasting blood sugar, it can cause more significant drop in your A1C. So the guidelines, especially the ADA guidelines, kind of have in terms of disease specific, weight specific, or glycemic, what do you start first? So a GLP-1, SGLT2, or metformin, and they give you some guidance on how to add on for the second line. So if the patient is already on an SGLT2 and needs more lowering, you can do a GLP, you could add metformin, but it doesn't really address really the robust data on a third or fourth line. So we talked about agents, but this is a meta-analysis study that looked at studies that patients who are on polypharm, so 3 or 4 medications. And as you see, if DPP4 is added on to a third agent, it doesn't give much additional lowering in A1C. So if a patient is at 9 and they're already on a GLP-1 agonist and metformin, and you consider even adding an SGLT2 inhibitor, you're only going to get 0.7% lowering. If you add on basal insulin, I think in these meta-analysis, they didn't titrate it. So it was 0.75% reduction in A1C because they're starting at a basal insulin of 10. But if it's titrated, you can have more robust lowering. And then GLP-1 receptor agonist gave as a third line reduction of close to 1%. But at 2018, they didn't have the robust medications such as Mounjaro or Ozempic, which can lead up to a 2.5% reduction. When we think of a fourth line oral addition, it's not really going to do anything. Because if the third line add-on of non-insulin and orals are not doing much lowering, a fourth oral add-on is not going to create much. So if you're thinking of a fourth agent and the patient is not on insulin therapy, you're going to consider doing basal therapy. So when we look at the ADA ACE guidelines and we look at that passive meta-analysis, this is kind of a evidence-based algorithm. So first line, if A1C at present is 2%, more than 2% above target, you're going to do combination. Also lifestyle modification, that can go a long way, especially if patients are drinking sodas and Kool-Aid and Tang and things like that. So lifestyle can have a great impact. You want to consider adding on a GLP-1 receptor agonist first, and then you can add on metformin after if needed. If patients are symptomatic and A1C is over 10, consider insulin therapy first, especially if they are having weight loss and catabolism. Second line would be if if you have medications on and they're still above 2% and they're not on a GLP-1, you would add on a GLP-1. If already on GLP-1, unlikely that metformin alone is going to get you to goal. It's unlikely that GLP-1, metformin, and SGLT2 is going to drop you more than 2% if you're not controlled on a GLP-1 alone. So you want to start thinking, okay, maybe we may need a dose of basal insulin. And if the A1C second line is less than 2%, then that's when you can consider some of the other agents. If not on a GLP-1, start a GLP-1. And this is showing the ascending order of kind of A1C reduction. DPP-4, not much. SGLT2, 0.7 to 0.91%. Sulfonylurea is a little bit more. And then pioglitazone closer to 1%. And it's always important to consider potency, cost, side effects, and patient preference. And when you're thinking of third line, consider if they're not on a GLP-1, add a GLP-1 because that can help with 2%, up to 2% reduction. Mounjaro up to 2.5% on high dosing. If the A1C is over 1.5% and not on a GLP, a potent GLP, consider insulin. And fourth line, if they're not controlled, start basal insulin. When you start basal insulin, that does not mean you're going to stop the other agents. You can keep some of them on, especially the ones that have cardiovascular benefit, kidney benefit. So you wouldn't stop the so you wouldn't stop the SGLT2 inhibitor or the GLP-1 or the dual agonist therapy. You will add basal insulin to it. And by doing it that way, you reduce the time. Sorry, you increase the time that patients may need prandial insulin, so Humalog or Novolog, and also you reduce the insulin requirements so that they don't have, as we know, insulin promotes weight gain. They don't have that robust weight gain if you keep on the GLP-1 or the SGLT2 inhibitor. So let's get to the cases. So this is JS. She is a 63-year-old woman with more than 20 years of type 2 diabetes. She's referred by her internist. She has no kidney or vascular complications. Her BMI is 24.5. Her A1C level has been suboptimal, ranging from 8.8 to 9.2% over the last year. She's on metformin, 1,000 milligrams BID. She's on Ozempic, and she's on Fosamax for osteoporosis. So she's on 1 milligram of Ozempic. She's recently visited her diabetes educator. She's following a nutrition plan. She's exercising at least 150 minutes per week. So she's a pretty good patient. So she's doing all of the lifestyle stuff. She has been advised to start insulin, but is fearful of hypoglycemia, having witnessed that her uncle had a hypoglycemic event as a child. So, I showed you the answer. But what would we add best for this patient? So because she's already on metformin, she's on semaglutide, she's still not at goal, A1C is more than 2% of target, the only thing that's really going to get her to goal is going to be basal insulin. So that's going to be the recommendation. So they recommended to start insulin degludec, which has a reduced hypoglycemic risk, but starting any basal insulin will be recommended. So you'd start at 10%, and then you'll have her titrate the dose based on the fasting sugar, and then titration usually happens every 3 to 5 days to target a blood sugar of 80 to 130 in the morning. So why are the other answers not quite right? After 20 years of diabetes, this patient likely has what we call burnout, right? So the beta cells are probably done. And so she has the insulin deficiency, and that's what's leading to her A1C being above goal. Insulin is the only agent that can lower A1C below 7% in this individual without any added risk. It is conceivable that the basal insulin may be insufficient, and prandial insulin may be required. So you may have to add on Humalog or Lispro for one of the meals or even 3 meals. But keeping the semaglutide on will help to cover some of the prandial issues. Yes, tirzepatide or Mounjaro is more potent than Ozempic, but starting the tirzepatide will only lead to a 0.5% reduction on top of if you switched it from Ozempic to that. It's not going to give you much difference. Similarly, increasing the dose of semaglutide from 1 milligram to 2 milligram will only lead to about a 0.3% reduction in the A1C. Yes, pioglitazone is on that list. It may have some benefit and it can reduce A1C by 1%. But this is insufficient. She's 9.2, so that's not going to get her to goal. And then also, this medication may increase her risk of fracture. And then, as I talked about, the DPP-4s are very weak. It's not going to do much. The next case is JR. He is a 56-year-old male with type 2 diabetes. His BMI is 30. His current meds are atorvastatin, metformin, 1 gram BID, insulin glargine 20 units, and lisinopril 10 milligrams a day. He's had type 2 diabetes for 3 years. He was initially started on metformin. He had a cardiac event, so he had an MI 2 months ago, and he has fatty liver. His A1C is 8.4, so he's suboptimally controlled. I wish we had audience response, but JR presents for the first visit to see you. His vitals are within normal limits. Renal function is normal. He has mild AST and ALT elevations. What is the best drug to initiate for him at this time? So is it going to be an SGLT2 inhibitor? Is it going to be semaglutide, which is the potent GLP-1 agonist, or is it going to be a weak GLP agonist, such as lixisenatide? So it's going to be Ozempic. It's going to be semaglutide. So he's on semaglutide 0.5 weekly with the metformin 1 gram BID and his glargine, which he's titrated down to 12. He has no side effects from semaglutide, but the A1C is 7.4, so it's still not at target. So what is the best management next for him? Would it be to discontinue metformin and continue insulin glargine and semaglutide? Titrate semaglutide up and continue insulin glargine at current dose, or C, titrate semaglutide up and titrate insulin down. So in this case, he's already started to come down on the Lantus because he's going up on the semaglutide. So I would recommend, because we're trying to treat his NASH, so we need more weight loss, is to titrate up the Ozempic, the semaglutide, and titrate down the insulin glargine, the Lantus. Because if you leave him on the same dose of Lantus, he's going to have hypoglycemia. So you always instruct patients who are on GLP-1 that you're adding on to insulin how to decrease the medications to prevent a hypoglycemic event. So that was the best option that I chose, because again, we want to prevent hypoglycemia, and it's all about patient safety while getting to a target A1C. So in summary, reduction of type 2 diabetes complications includes glycemic blood pressure and lipid management, and use of agents that have cardiovascular and kidney benefits. GLP-1 receptor agonists and dual therapy GLP-1 receptor agonists and GIP agonists have demonstrated significant reduction in A1C, cardiovascular events, and CKD. They have demonstrated resolution of NASH and improvements of fibrosis. SGLT2 inhibitors have demonstrated reduction in cardiovascular death, heart failure, and incidence of worsening nephropathy. The guidelines have evolved from a glucocentric approach to a cardiorenal approach, and now to a cardiorenal obesity approach. We know weight loss can lead to remission, so we should be targeting that as a primary outcome. Type 2 diabetes medications have evolved. So they're no longer hypoglycemic agents that just lower blood sugar and that's it. They're true anti-diabetic agents that target the defects and cause disease modification, and even in some remission of the disease. Remember, published guidelines are only a guide. We still got to use our brain. We have to think about how much lowering does this A1C do, how to add on therapy, and then how to prevent futile polypharmacy, and when to start insulin therapy. Consider combination therapy to prevent therapeutic inertia and to prevent morbidity and mortality in the future due to high sugars. We talked about avoiding feudal polypharmacy. You have to understand how the meds work. It takes into consideration patients' A1C, duration of diabetes, weight, and comorbidities. And that is it. Is there any questions? And if you have additional questions, I'm happy to answer them now. And if you have questions in the future, these are my contacts. Thanks for listening and spending the morning with me, part of the morning.
Thank you so much, Dr. Davis Simmons. That was indeed a very comprehensive, well done presentation. Lots of information, very useful information that I'm sure all of us can use in our management of diabetes. So thank you for taking your time to update us on the latest information regarding the management of diabetes. We thank all of you participants for staying with us. We had a lot of people on the call. We still have a lot of people on the call. And as we get into the question and answer section, I want to just quickly remind everyone to fill out your feedback. Fill out your feedback, please, and remember to adjust your names to the name that will appear on your BMC certificate. So if you have a first initial and surname, we don't know who you are. If you are iPhone, Samsung, we don't know who you are. So please make that adjustment. Okay, so let's get to some questions and comment. Dr. Frankson has chimed in. Dr. Frankson has said, excellent, comprehensive overview, much appreciated. Dr. Carroll says, good morning. Thank you, Dr. Simmons, for an excellent, comprehensive presentation. What additional recommendations would you make for addressing therapeutic inertia in our public setting where resources are limited and non-compliance is common?
Yeah, so great question. So in our public setting, so remember we talked about it's not all medication. So it would be self-care is what I would say is a way to kind of help with the A1C. So getting them with a diabetes educator who are available in the public sector, getting them in with nutrition, so that we can focus on self-care. And some of the really good newer medications I talked about, maybe not the GLP-1s or the combination GLP-1 GIP, but the SGLT2s are on the formulary for the drug plan. So there are still good medications. So SGLT2, you still have metformin. And for my individuals who may not have the funds, I may even use a little bit of Actos, which can help with NASH and help with A1C lowering. So we do have the tools. We may not have the new kids on the block, the newer kids on the block, but we do have good medications. I would say focus on self-care, and then adding the meds in a timely manner. And then when to start insulin therapy. So a lot of patients are resistant and the doctor may be resistant, but if they're on 3 agents and A1C is still high, that's the time to start basal therapy. So that would be my recommendation.
Okay, thank you for that. So remember to encourage patients to get with their educators indeed and do what they can do on their end. Dr. Strawn Bolek says, excellent presentation, Dr. Davis Simmons. Thank you. Anishka's iPhone. Anishka, could you please put your full name? Anishka's iPhone said, thank you for such a thorough and very important presentation. Excellent. And Dr. Carroll thanks you for your response to her. Are there any additional questions or comments for Dr. Davis Simmons? Okay, there doesn't seem to be any further comments or questions. Okay, Richardson Desmango said, I enjoyed this presentation, very informative.
Thank you, guys.
Yes, thank you for all of your comments. Thank you for all. Okay, Dr. Parkinson says, very comprehensive and enlightening. Okay, thank you guys for your comments. Thank you for your participation with this morning's CME. And again, thank you, Dr. Davis Simmons, for taking the time to inform us of this very, very, very important topic. And please know that with this updated information that you have provided us, we will definitely take it and run with it and do the best by our patients. Thank you once again.
Thank you. Have a great day.
You too. I'll see you guys at our next CME presentation, which will be the second Wednesday in February. Take care, guys, and I hope you enjoyed this morning's lecture. I most certainly did. And guess what? You have just leveled up. Have a good day.